All right. So I am delighted to be able to tell you that this is only the second time I've given this talk in my life, because I must have been talking on hypertension for 35 years, but we haven't had a new guideline in 14 years. And this is the new hypertension guideline. It's finally here. How many of you are familiar with the new guideline by a show of hands? Okay, good. This is going to be a quick down and dirty. These slides are all here for you. You should, and I know you will need to refer to them in the future to try to get a handle on what we're saying in this new guideline. But the subtitle is 130 over 80 is the new 140 over 90. Here are my disclosures. Here are the objectives. 1, be familiar with the new 2017 ACC AHA Guidelines, including the definition of hypertension and how they changed the U.S. population at risk for hypertension. 2, be familiar with the best approach to measure blood pressure. I can't emphasize this enough. The measurement of blood pressure is so important for everything we do with our patients. It has to be done properly. We will really spend some time on that. 3, recognize the importance of lifestyle modification for the treatment of hypertension. With the prevalence of hypertension going up, lifestyle modification is going to be more important, because many of the new hypertensives, quote unquote, will not have high risk, because many of them will be less than 45 years of age, and because their absolute risk is going to be all that's recommended. 4, be familiar with the current first line for the treatment of hypertension. And 5, recognize what blood pressure goal or target is recommended to best improve cardiovascular outcome. Okay. For the new guidelines, it's endorsed and written by the ACC AHA with 9 other organizations, a total of 11 organizations. The reference there is on the bottom of each slide. And it's for the prevention, detection, evaluation, and management of high blood pressure in adults. Please notice that the American College of Physicians and the Academy of Family Physicians, 2 representative organizations that have many members or many people that are of those disciplines in our audience today, they have not been part of this writing group. I will tell you the AAFP will be coming out with a new summary on this guide. And the ACP has already written a guideline, which I will come out and show you. Okay, moving on. Here is the writing group. And those are all of the organizations on the bottom left of the slide, which you can see down here. Okay. In 1972, under Health and Education, Elliot Richardson developed a hypertension working group. And 5 years later, the National Heart, Lung, Blood Institute developed the first Joint National Committee, 1977. At that time, the target for blood pressure intervention based, and it was at a diastolic of 105 or greater. If the patient had high risk from 104, you could consider treating that patient for hypertension. But in 1977, it wasn't based on the top number, it was based on the diastolic pressure, and it was a threshold of 105. 4 to 5 years, another Joint National Committee group came out, and over time, the evidence suggests target, and in the 1990s with the SHEP trial, published in 1991, we realized in the adult the importance of the top number, or systolic blood, that often as a target for intervention. We continued until 2003 with JNC 7. We did have a report that some referred to as JNC 8, but it was never officially endorsed. Heart and Blood Institute, NIH, got out of the guideline business, sent it over to the American College of Cardiology and the American Heart Association, and they have developed this new 2017 guideline. Continue to use an evidence-based strategy to evaluate the evidence for why we make certain recommendations, both in a recommendation and a quality or level of evidence. And you probably will this slide as we go through or as you review the talk from class 1 2A, and the colors will be coded 2B, 3 where there's no benefit, and 3 in red where there's harm. Level of evidence A, then it goes down to B from at least one randomized trial or meta-analysis that has randomized patients in it. B, non-randomized, then C with limited data, less evidence, and then C, expert opinion. And finally, this document was 3 years in the making. It is 192 pages, so I'm going to give you the Cliff's Notes version of it today. Okay, so on the left-hand side, cigarette smoking, diabetes, dyslipidemia, being overweight or obese, physical inactivity, an unhealthy diet, relatively fixed cardiovascular risk factors or chronic kidney disease, a persistent estimated GFR less than 60, or clinical proteinuria, more than 300 milligrams of albumin per gram of creatinine on the bottom of the slide, family history, non-modifiable, age, of course, low socioeconomic educational status, male gender, obstructive sleep apnea, and psychosocial stress. Now, there's a new classification and a new epidemiology of blood pressure. And here is that Lewington slide, I'm sorry, and it shows very nicely the graded relationship from left to right of systolic blood pressure starting at 115 and going up to 185. Every 20 systolic increment and every 10 diastolic, not shown here. And based on age, you can see that death from ischemic heart disease goes up significantly. So there's a graded risk at blood pressures less than 120 over 80, but certainly the higher the blood pressure, the greater the risk. And this curve is even steeper for stroke-related mortality. This is done in 1 million adults registered and followed over time, 45 to 67 to 89 years of age. Now, very importantly, we used to use the term pre-hypertension. But when you look at the association between systolic and diastolic blood pressure and cardiovascular risk, several meta-analyses have reported a gradient of progressively higher cardiovascular risk from normal blood pressure, less than 120 over less than 80, to elevated blood pressure, 120 to 129 over less than 80, to 130 to 139 over 85 to 89, which is now part of stage 1 hypertension. And you can see the risk is almost twofold increased for stroke and MI. So the committee felt that calling this pre-hypertension, as if it's not really incriminated in endpoint data or in risk, was a mistake. And based on clinical trials that I will go over with you that have achieved goals of 130 over 80 or less and epidemiologic risk, the committee has decided that the threshold for calling hypertension should be reduced from 140 over 90 to 130 over 80. So they recommend that blood pressure should be categorized as normal, elevated, stage 1, stage 2, to prevent and treat blood pressure. Normal blood pressure, less than 120 over less than 80, unchanged. Elevated blood pressure, 120 to 129 over less than 80. Stage 1, 130 to 139 over 80 to 89. And stage 2, 140 over 90 or greater. There is no longer stage 3. We got rid of that in JNC 6. And all blood pressure elevation above 140 over 90 is stage 2 hypertension. In order to make a diagnosis of hypertension, you must have at least 2 or more readings at 2 or more settings, and as I'll show you, it is strongly encouraged that blood pressure is confirmed with an out-of-office measurement. More to follow. So when we compare the previous categorization of JNC7 with pre-hypertension to the 2017 ACC AHA, the new guideline on the right, you can see normal blood pressure is the same. Pre-hypertension now is broken into elevated blood pressure and stage 1 hypertension. The old stage 1 becomes stage 2, and the higher stage 2 is still stage 2 in this current new classification of blood pressure. Now, when you look at the epidemiology of what this does, on the far right is the JNC7 classification, threshold 140/90 or greater, or being on antihypertensive medication, and compare that to the new threshold of 130/80 or greater, or being on antihypertensive medication. The prevalence of hypertension increases from 32% to 46%, just short of half of American adults 20 years of age and older will be classified as hypertensive. However, most of that increase is in men and women less than 45 years of age who will continue to need only lifestyle modification as we develop this, because their risk is not high, they do not have underlying atherosclerotic cardiovascular disease, diabetes, or kidney disease. And although women are increased about twofold and men less than 45 threefold, lifestyle modification will still be the primary target for these individuals. Notice that blacks still have the highest prevalence of all ethnic groups with hypertension. So, in summary, the prevalence of hypertension from JNC7 to the new guideline is going up from about 32 to 46%, and the millions of hypertensives, we used to say there were about 70 to 75 million with hypertension. It's now at 103 million, based on the new definition. So let me summarize, as I will, as we go through some of these important points. At a threshold of 130/80, there will be more patients diagnosed with hypertension, and this addition appears to triple the number of men 20 to 45 years of age and double the number of women 20 to 45 years old with hypertension. Lifestyle modification alone is a Class 1 recommendation for those with elevated blood pressure and stage 1 hypertension, with low, less than 10% ASCVD risk. More to follow on this in a minute. And in all those requiring antihypertensive therapy. So it's lifestyle for everyone, including those that need drugs, but most of these newer patients, lower risk patients, less than 45 years of age, will only require lifestyle, and that's in the third bullet. It is projected, based on risk under the new guideline, that only about 2% of patients, more patients, will require drug therapy from JNC7 to the new document from 34 to 36%. Okay. Let's go under the measurement of blood pressure. I can't emphasize this enough. This is how you set up your office. This is how you need to get your patients to the office early. This is what instrument are you going to use in your office to measure blood pressure. And I can tell you, although we've always used automated oscillometric blood pressure devices, AOBPs, in our clinical trials, the committee felt that to put the economic burden on clinics across America to buy AOBPs was not appropriate. And so they have allowed a rollout, including auscultatory blood pressure measurement, to be used in the office. For diagnosis and management of high blood pressure, proper methods are recommended for accurate measurement and documentation of blood pressure. This is a Class 1, Level C expert opinion. And once again, they're emphasizing 2 or more blood pressures at least on 2 or more occasions before you call the patient hypertensive. Dylan, I for some reason, this is weak, but hopefully it'll move. Okay, so he says, the clinician, to the patient, I'm going to take your blood pressure, so try to relax and not think about what a high pressure might mean for your chances of living a long, healthy life. There should be no conversation. I'm not even sure the clinician should be in the room, but we'll go through how they say blood pressure should be measured. All of the things that I'm circling here are going to cause a false elevation in blood pressure. It's going to give you a sense that the blood pressure is higher than it really is, and is going to trigger you to consider therapy when perhaps you're dealing with a falsely elevated blood pressure. The communication. The blood pressure measurement device on the wall encourages the patient to be on a table with their feet dangling, elevation, false elevation. She's startled. Feet are off the floor. Back is not supported in a chair. She's pushing off on the table. And the cuff size is too small. Well, I don't know. I guess it's not strong enough to get to the back, huh? Dylan? I'm not sure what to do. Okay, there we go. So let's go through how to measure blood pressure appropriately. Properly prepare the patient. This is all in your handout. Have the patient relax, sitting in a chair, feet on the floor, back supported, for at least 5 or more minutes. So we want the patient to come into the office earlier than their appointment, not circling around the office or the clinic or the VA, fighting for a parking spot, coming in at the last minute, and being rushed to get a blood pressure. The patient should avoid caffeine, exercise, and smoking for at least 30 minutes before measurement. All from the document. Ensure the patient has emptied her bladder or his bladder. Neither the patient nor the observer should talk during the rest period or measurement. By the way, if you're a hospitalist and you're called to the ward in the middle of the night because Mrs. Jones has an elevated pressure, make sure you percuss her bladder or ask if the patient has gone to the bathroom, because she may have a voiding problem, and that'll cause an elevation in the pressure. Neither the patient nor the observer should talk during the rest period or measurement. When I got my hips replaced and I went back to the orthopedic clinic, they slapped on a blood pressure cuff, took my medication reconciliation, and asked me my pain score in the same sentence. My blood pressure was 22 millimeters systolic higher than when I told her the proper way it should be taken. And let me relax. Absolutely true. Absolutely true. But this is what's going on in our clinics. This is a real concern, folks. A real concern. Remove all clothing covering on the location of cup placement. Watch CBS News, CNN, whatever you watch, Fox. When they have a healthcare segment on hypertension, they're always taking blood pressure over a shirt, over a coat. No, bare arm. Measurement should not be made with the patient sitting or lying on an examination table. Feet on the floor, back supported, chair, comfortable. Still got a problem. Okay, step 2. Use a blood pressure measurement device that has been validated and ensure the device is calibrated periodically. We're going to encourage home blood pressure measurements. Patients can't use a auscultatory measurement. They have to use an automated oscillometric blood pressure device. And they can buy those at CVS, Costco, Revco, Sam's, BJ's, wherever you want to go. They all have ones that are about $50. Omron makes one, Welsh Allyn, a little bit more expensive. They can bring those monitors to your clinic. You can see how they take their blood pressure at home. You can see what you got with your measurement, what they got with their measurement on that same day. Support the patient's arm. It's like a phlebotomy arm, so somehow you have to support them. Position the middle of the cuff of the patient's arm at the level of the right atrium, the midpoint of the sternum. Use the correct cuff size, I'll show you that, so that the bladder encircles 80% of the arm. And note if a larger or smaller than normal cuff size is used. Either the stethoscope, diaphragm, or bell may be used for auscultatory readings. How many of you, just out of interest, have automated oscillometric devices in your clinic and you're not taking blood pressure with auscultation? How many are using auscultation? Okay, this is impressive. If we did a clinical trial and used auscultatory measurements, you would never believe the trial, because we all deflate at different speeds. We all use a different obliteration pressure. We round off to the nearest digit. We take blood pressure differently. And we have hearing differences. And so if you're the only one in the office or the only one seeing the patient, there may be some standardization there. But it is a concern. And this is what the committee was dealing with. Automated oscillometric blood pressure devices are highly recommended to import into your clinics. But if you're going to use auscultation, please refer to these different steps. These are the selection criteria for the measurement of blood pressure in adults, and you can see the mid-arm circumference and the usual cuff size. You take a tape measure, you measure the 80% of the mid-arm circumference, and you use the proper cuff size. Too small of a cuff size will overestimate the blood pressure in many patients with a very big arm. Step 3, take the proper measurement needed for diagnosis and treatment. At the first visit, record blood pressure in both arms. Designate the patient as a right or left-armed person where the higher pressure is. Separate repeated measurements by 1 to 2 minutes. For auscultatory determinations, use a palpated estimate of the radial pulse. Put your finger on the radial pulse, blow up the cuff. Once the radial pulse is obliterated, go 20 millimeters above that obliteration of the radial pulse. That's the obliteration pressure, and then slowly descend 2 millimeters per second to get the first Korotkov sound, and finally the dissipation of all Korotkov sounds. Systolic, first Korotkov, diastolic, dissipation of all sounds. Step 4, properly document accurate blood pressure readings. This talks about the Korotkov sounds. Note the time of the most recent blood pressure medication taking before measurements. In the document, chlorthalidone is recommended based on the duration of action and the evidence based at 12.5 to 25 milligrams for improvement in outcome. HCTZ has a shorter half-life, so if they take HCTZ 3 hours before they come to the clinic, their blood pressure may be controlled in the morning, but it may not be controlled in the evening. And this is why they're putting in here, let the patient know when they last took their medication. Because if they're always seen in the morning and always on short-acting medicines, they will appear to be controlled when actually throughout 24 hours they may not be controlled. Use an average of 2 or more readings obtained on 2 or more occasions, and then tell the patient what their blood pressure is verbally and in writing. Next slide. Out-of-office blood pressure measurements are recommended to confirm the diagnosis of hypertension and for titration of blood pressure lowering medication in conjunction with telehealth counseling or clinical interventions. So there's a real emphasis on the patients involved in their care, getting you their out-of-office measurements to make sure that the blood pressure is truly elevated. And in the document it says the following: if the blood pressure is 130 to 160 or 80 to 100, be sure you rule out white coat hypertension by getting out-of-office measurements from the patient to make sure that their blood pressure isn't normal at home and only elevated in the office before you give them a diagnosis of hypertension. In addition, if their blood pressure is 120 to 129 in the office and less than 80 in the office, they may have masked hypertension. That is, they're close to the mean, they're close to the hypertension threshold, and they're actually high at home. Their hypertension is masked to you. So 2 new terms, white coat, you know about white coat, and masked hypertension. And they say if they're white coat, consider just following the patient. Don't lose them to follow-up, because some of these patients with white coat will, over time, develop hypertension. But currently, white coat hypertension is not nearly at near the risk of true hypertension. Masked hypertension, on the other hand, we don't have good trials yet on masked, but they suggest in the document you may consider pharmacologic therapy for masked hypertension, which is more likely to occur in women than men, blacks than whites, and in chronic kidney disease. We're learning more about it, but that's what they say. That's why they're really emphasizing out-of-office blood pressure measurement. Next slide. I need some help with this. So, in summary, new emphasis is placed on out-of-office blood pressure measurement. I don't think you're going to be able to practice hypertension medicine without a patient getting their blood pressures measured at home. Home and ambulatory blood pressure measurements are recommended to confirm the diagnosis. 24-hour AMBP is best, but they're not going to pay for it unless you confirm or trying to confirm white coat. And so cost can be an issue. The committee didn't feel that they could recommend as a level 1 home ABPM, but they suggest it. But this represents a more rigorous approach to the diagnosis of hypertension. Clearly, it's not just what happens in the office, and we know out-of-office measurement predicts risk better than in-office measurement. Okay. When you look at the type of blood pressure readings that you're getting, you're truly normotensive. When you have normal in the office and out of the office, you have sustained hypertension. When you're elevated 130 over 80 in the office and 130 over 80 out of the office or greater. You have white coat when you're only elevated in the office. It could be 130 to 160 over 80 to 100, but out of the office, They're not alerted, they're not reactive, they're calm, their blood pressures are normal, need to know that, and they could have MAST. And where do you start thinking of MAST? 120 to 129 in the office, often diastolic normal, because they appear to be less than 130 over less than 80 in the office, but at home, they're actually higher. So you've really got to get home and office measurements on multiple sittings, multiple visits, before you give them a diagnosis of hypertension. So let's summarize this. There's a new emphasis placed on the importance of white coat and MAST hypertension. Managing these two new phenotypes of hypertension will be new to most clinicians and will require additional information. Okay. Next slide. Patient evaluation. Not much new here. A BMP is what most of us get. That includes a fasting blood glucose, a CBC for overall health, a lipid profile, an estimated GFR that's now calculated by the lab, a sodium, potassium, and calcium, a TSH, a urine, and an EKG. Optional testing, echo, uric acid, and urinary albumin to creatinine ratio. Okay? Optional. Not recommended in most hypertensives. Okay. Secondary cause of hypertension I'm going to talk about tomorrow when I talk about resistant hypertension, so we'll talk about that then. Screening tests and cause of secondary hypertension are similar to recommendations made in the past. This is a summary slide from the new 2017 guideline. Not much here about the basic tests, not much here about the screening tests. Non-pharmacologic interventions, the cornerstone of treatment of hypertension in 2017. Trials have shown the benefit of lowering blood pressure among those with systolic diastolic pressures of 130 over 80 or greater through non-pharmacologic lifestyle modification. Weight loss, for every kilogram reduction in weight, systolic reduced 1 millimeter. A heart-healthy dietary approach to stop hypertension. This is a high, just like we had outside today, a high fruit, perhaps vegetable diet, low in non-dairy fat products, and low in sodium, especially in the African American, in the elderly, in the patient with chronic kidney disease. Sodium reduction, although they recommend less than 1,500 milligrams per day of sodium, the most important point is to reduce sodium intake from processed foods and dietary cultural foods by 1,000 milligrams from the baseline. And you will need a dietitian often to do this, and we hope in the future they will bundle the dietitian's visit so there's no extra cost. This is going to be hard to do as a clinician. We're going to need dietary professional help on this, I believe. Physical activity, it's the same. 30 minutes a day, recommended 5 sessions a week. Aerobic can be dynamic resistance exercise as well, and alcohol reduction. I'll summarize that. Basically, it's no more than 2 drinks in men, no more than 1 drink in women. I like to keep it at 1 drink in both. Many times, we don't really get an accurate alcohol history from our patients. Now, I put this in here because this is the diet rich in potassium. Epidemiologically, high potassium societies around the world have less stroke and less cardiovascular disease. A high potassium diet begets a low sodium diet. Raisins, prunes, apricots, dates, strawberries, bananas, watermelon, cantaloupe, citrus fruits, beets, greens, spinach, tomatoes, mushrooms, peas, beans, soy products, veggie burgers, turkey, beef, fish, salmon, and cod. All high potassium foods. I have a sheet that I give patients off of a Word document. So, all class 1 level of evidence A for all the lifestyle modifications. I'd ask you to read this. And when you look at the alcohol there, adult men and women with elevated blood pressure or hypertension who currently consume alcohol should be advised to drink no more than 2 and 1 standard drinks per day, respectively. And then they define what that drink is, okay? So it's basically 5 ounces of wine, 12 ounces of beer, and 1.5 ounces of distilled whiskey, distilled spirits. Summary: lifestyle modification has a large place in management. Weight loss, sodium restriction, DASH diet, exercise, potassium replacement, moderation of alcohol. You've seen this before. The potassium is kind of new. Can additively decrease systolic, often 5 to 15 or 20 or more by using multiple lifestyles together. Lifestyle modification alone is a class 1 recommendation for those with elevated blood pressure and stage 1 hypertension with low, less than 10% risk of ASCVD over the next 10 years, and in all those requiring antihypertensive drug therapy. Let's get to the targets. We've been on a roller coaster ride over the past 15 years. We have really confused you. If you've been a reader, you've been seeing that different groups have been coming out with different targets, and it's been a little bit disconcerting and a little bit frustrating to many clinicians. We have recently recommended systolic targets in different populations, including in 2017, less than 150 in patients 60 years of age and older. It's now less than 130. Less than 140 in JNC7 overall, and less than 130 only in those with chronic kidney disease and diabetes. We kind of went back to the 140 over 90. When you look at the 2017 reference here from the American College of Physicians and the American Academy of Family Physicians, the two groups that did not take part in the 2017 guideline, they say that the strongest evidence in people 60 years of age and over from clinical trials is when the systolic is 150 or greater and you get it to less than 150, with weaker evidence in higher risk groups at 140 or greater to less than 140. Not what the new document is recommended. In JNC7, 2003, 14 years ago, you'll remember it was less than 140 over less than 90, but if you had diabetes or chronic kidney disease, it was less than 130 over less than 80. But that was abandoned in JNC8 because we didn't have good clinical trial evidence to support that. Well, since then, we've looked at the diabetic, comparing 120 to 140. We've looked at the non-diabetic in high risk with CKD, less than 120 to less than 140, and we have new evidence. And that's what the guideline has now based a lot of its recommendation, 2017, on. So when you talk about drug therapy, you should be comfortable using lifestyle and drug therapy in patients with 130 over 80 or greater hypertension and established ASCVD, chronic kidney disease, and diabetes. I'll show you some of the evidence. Or stage 1 hypertension, and the risk calculator, which I'll show you in a minute, is going to calculate from your phone, which I have on my phone, just as a quick calculation, quick I say in quotations, of greater than 10%. When the absolute risk of that individual with a particular blood pressure is 10% or greater, it's lifestyle and drug, and when they're stage 2 hypertension. Independent of risk, but just based on the height of the blood pressure, lifestyle and drugs. Target less than 130 over less than 80. Now here is this new ACC AHA pooled cohort equation, and here is the website that you all can use, and you can get on this while I'm talking, or you can get on this when you get home or back to your room tonight. And it's pretty nice to use. If you're 40 to 79, it gives you your lifetime risk of ASCVD. You also could compare previous patients to now a year in follow-up. And like the lipid calculator, which uses a threshold of 7.5%, because in hypertension, the threshold for risk was at 10%, they used 10% as their target. And still having trouble. Okay, so here is the lipid calculator. We're using the same parameters, their gender, their age, their race, their total HDL cholesterol. They do ask you for LDL cholesterol in the new risk calculator, and they ask you if they're on a statin or not. That is built into the LDL, and it's just trying to tell you if your patient's risk is at 7.5% or greater, they may suggest, if the patient's not on a statin, that you add a statin. It also asks for systolic pressure. Are they on treatment for high blood pressure with drugs? Are they a diabetic, and are they a smoker? And it will give you their 10-year ASCVD risk with the threshold at 10% or greater. So, okay. It also asks you about aspirin. And if the risk is less than 10%, and they're not 50 to 59 years of age, the United States Public Service Task Force commitment, and we'll talk about this on Sunday, to aspirin is less. So it may suggest that the patient is not the best candidate for aspirin as well. But it's really interested in calculating the risk. The problems with the calculator is that when you're 65 years of age and a male, even if your blood pressure is 130 over 80 and your LDL is 80 and all your parameters are low risk, you'll calculate out at 10.1%. So 65 years of age is sort of an age cutoff where you're likely to be at high risk just on the basis of age. Not so much in women where it's about 62 years of age. Okay, are we moving on? So this summarizes what you do at different blood pressures. And when the blood pressure is normal, less than 120 over 80, for blood pressure, you see them back in 1 year. You have them monitor their blood pressure at home and get in touch with you if they may have masked hypertension or their blood pressure is starting to increase sooner than a year. If they have elevated blood pressure, it's lifestyle modification, follow up in 3 to 6 months. If they have stage 1 hypertension, without ASCVD, chronic kidney disease, or diabetes, calculate their risk. If less than 10%, lifestyle only, see them back in 3 to 6 months. More than 10%, which is right here, if I can get that to show you, nope, on the fourth from the left there you're going to use lifestyle and pharmacologic therapy. And if they're stage 2, it's pharmacologic therapy. It's all spelled out there on the slide for you to review it. Adults initiating a new or adjusted drug regimen for hypertension should have a follow-up evaluation for adherence and response to treatment at monthly intervals until control is achieved. This is going to put a little bit of concern on how many open slots you may have, on how you develop your panel, on how many are in your panel, how many have hypertension, but this is what is recommended. Lifestyle only, 3 to 6 months, drug every month until they're controlled, when you then can back off to every 3 to 6 months. Okay. Now, the ACCORD trial compared in type 2 diabetics a systolic of less than 120 to less than 140. And it had 4,733 patients in it, and we were able to get them from a mean of 139 down to about 133.5 in the standard group. And we were able to get them down to a mean of 119, just below 120. About a 14 millimeter difference in the two blood pressures. It took about one more class of antihypertensive to get them to 119 versus 133. But in the primary endpoint, the only two endpoints of the primary composite endpoint that drove the benefit, which you can see was 20% reduced, but overall the primary was not less than the confidence interval of 1.00. The only two endpoints was stroke. Stroke was reduced, but there were few endpoints. And this is why at the time, the blood pressure target for diabetes was put back to less than 140, and here we achieved about 134. Now, gosh. I don't know what the problem is. Okay, in the SPRINT trial, non-diabetics, 4 high-risk groups. We compared less than 120 to less than 140. This was published several years after ACCORD. And here they had to be at least 50 years of age and be high risk with a blood pressure of 130 to 180 on entry. And they had to be in 4 high-risk subgroups. They had to have clinical or subclinical cardiovascular disease, but not stroke, chronic kidney disease with a GFR of 20 to 59, so 3A, 3B, a little bit of 4, but they couldn't be pre-transplant or near dialysis. They had to have a Framingham risk score that was elevated, 15% or more. The mean in the total trial was 20%. So these were very high-risk, older individuals, at least 50 years of age, and one group, 28%, were 75 years of age and older. In these non-diabetics, which we went from about 140 to 136 compared to intensive 121, we didn't get below 120, there was a benefit in the primary endpoint. It took one more class of medication. And here you can see a 25% reduction in the primary outcome, mostly driven by the prevention of heart failure and death from cardiovascular disease, the 2 asterisks on the bottom of the slide. But in addition, those targeted to less than 120 compared to less than 140 lived longer. All the subgroups, total death was reduced. This was a blockbuster trial that used automated oscillometric blood pressure measurement done the proper way. Here are the components. The primary outcome, 25% reduced at the top with a significant p-value, and driven by prevention of heart failure. And this will come up tomorrow when we talk about heart failure and the new target for preventing heart failure, less than 130 over less than 80, and cardiovascular death. When they went back, an important slide, and did a meta-analysis of both the ACCORD trial and the SPRINT trial, they found that they believed ACCORD was underpowered to show a benefit of less than 120 compared to less than 140. And when they put these trials together, but yet looked at ACCORD on its own, they found a benefit for a lower pressure. So in an effort to sort of have a middle ground in both the diabetic and those with chronic kidney disease, they settled on a target of less than 130 in your office, the way you take blood pressure, which may be closer to the 119 or 121 in ACCORD and SPRINT respectively, the way it was taken in the clinical trials with automated oscillometric blood pressure measurement. Next slide. Then they went back in SPRINT, non-diabetics, and on the right-hand side looked at those with pre-diabetes, glucoses on entry of 120 to 125, compared on the left with those with glucoses of less than 100. And both groups benefited from the lower blood pressure. So in an effort to try to get some unanimity in what they were recommending for the target of blood pressure, they picked less than 130 over less than 80, office corroborated with out-of-office blood pressure. But the bottom line is individual patient interaction for shared decision-making is essential when you practice hypertensive medicine in your office. Very, very often stressed in the document. In diabetes, in this 2017 meta-analysis with 43 studies, 30 of which were diabetic, and they looked at cut points of 120 to 124 versus higher blood pressures in those trials, or 130 to 134 and higher blood pressures in those trials, going up higher and higher. The lower pressure always reduced major cardiovascular events and all-cause death. So they picked less than 130 and a target of 130 over 80 or higher. Overall, when you look at this same meta-analysis and you target a blood pressure of less than 130 over less than 80, you significantly reduce MI, stroke, heart failure, cardiovascular disease in high-risk individuals, chronic kidney disease, diabetes, high-risk individuals. So a target of less than 130 may significantly reduce the risk of MI, stroke, heart failure, and major cardiovascular disease events. So in summary on this portion, several large randomized controlled trials testing intensive blood pressure targets have concluded the JNC7 report, have concluded since the JNC7 report in 2003. Systematic review, meta-analysis, and one randomized controlled trial, SPRINT, provide strong evidence for recommending less than 130 over less than 80, including those with elevated risk for CVD, 10-year risk from the calculator, 10% or more, known ASCVD, diabetes, chronic kidney disease, and in most, 65 years of age and older. They will have a risk of 10% or more. What about antihypertensive drug therapy? This has also been a roller coaster, but we are recommending as the first three class of antihypertensives, as we did in the document that was, quote, called JNC8, in no particular order, a thiazide-type diuretic, a calcium channel blocker, and an ACE or an ARB, but not both. The document goes on to say in African Americans, a thiazide diuretic and a calcium channel blocker are preferred for the initial agent, but in most African Americans, 2 or more agents will be required. Here is the level 1, class 1, level of evidence A from systematic review. For initiation of antihypertensive drug therapy, first-line agents include thiazides, CCBs, and ACEs or ARBs. Next slide. Comorbidities. In adults at increased risk for heart failure, the optimal blood pressure in those with hypertension should be less than 130 over less than 80. New recommendation. Diabetes. In adults with diabetes and hypertension, antihypertensive drug treatment should be initiated at a blood pressure of 130 over 80 or higher, class 1, with a treatment goal of less than 130 over 80. In adults with diabetes and hypertension, all first-line classes are acceptable and effective, useful and effective. No longer should anyone hold you to the ACE or the ARB as initial therapy in a type 2 diabetic, especially in an African American type 2 diabetic, where the thiazides and CCBs may get a more robust blood pressure reduction. It's only when they have clinical proteinuria that the ACE and the ARB or CKD out-trumps the other two classes. In adults with diabetes and hypertension, ACEs or ARBs may be considered in the presence of albuminuria. May be considered. It's a 2B. Okay, that's new. And the ADA has also embellished this. By the way, the ADA still is recommending less than 140 over less than 90 in diabetes. They have not endorsed this, just so you know. Chronic kidney disease, adults with hypertension and CKD should be treated to a blood pressure of less than 130 over 80. In adults with hypertension and CKD, stage 3 or higher, or stage 1 or 2 with albuminuria, clinical proteinuria, treatment with an ACE inhibitor is reasonable to slow kidney disease progression, and it gets a higher recommendation than treatment with an ARB. But if they have cough or another reason you can't use an ACE, an ARB can be used. But this is new. Based on the clinical trial evidence, they feel more confidence in recommending an ACE inhibitor in type 2 diabetes than an A or B. Interesting. Simultaneous use of an ACE and an ARB. An ACE and a direct renin inhibitor, or an ARB and a direct renin inhibitor, is potentially harmful. We will not do it in primary care. If the nephrologist wants to do it to reduce proteinuria, let them write those prescriptions. There's more hypotension, syncope, hyperkalemia, and acute kidney injury when you use two RAS blockers together. Next. In black adults with hypertension, including those with diabetes, initial antihypertensive treatment should include a thiazide or CCB. And this is where they go on to say 2 or more antihypertensive agents will often be required to get to less than 130 over less than 80. I just threw this in for you because many of you see patients that will become pregnant. Women with hypertension who become pregnant or are planning to become pregnant should be transitioned to methyldopa, nifedipine, and or labetalol during pregnancy. 1C limited data. Women with hypertension who become pregnant should not be treated with ACEs, ARBs, or direct renin inhibitors. Older individuals, treatment of hypertension with a systolic treatment goal of less than 130 is recommended for non-institutionalized ambulatory community dwelling greater than 65 years of age adults with an average blood pressure of 130 or higher. That's from the SPRINT trial. They couldn't be in a nursing home. They had to be ambulatory. So people that are prone to orthostasis or are living in a nursing home or are not ambulatory or cognitive decline or have a cancer and a limited life expectancy, you pick the best blood pressure for them. If they develop symptoms while you're trying to get to 130 over 80, you won't be able to do it. You pick the best pressure as you're treating them to try to get to less than 130 over less than 80. But it's informed decision-making, it's patient-informed decision-making, and it's documentation in the chart for that. For older adults with hypertension and a high burden of comorbidity and limited life expectancy, clinical judgment, patient preference, and a team-based approach to assessment, risk, and benefit is reasonable for decisions regarding intensity of blood pressure lowering and choice of antihypertensive goals. So these are the subgroups in the older patient where you may pick a higher threshold of 140 over 90 as your goal. Prevalent recurrent falls, dementia, including Alzheimer's, high burden of comorbidity, neurogenic orthostatic hypotension or orthostatic hypotension, nursing home residence, and limited life expectancy. Nobody can tell you what the goal, the target should be. These are guidelines, okay? You are the clinician. You decide what's best for your individual patient and as you're following them. Take-home messages. We've been on a roller coaster ride over the past several years trying to select the best target for blood pressure control. This new guideline tries to make that ride smoother and more even. How you measure blood pressure and secure the diagnosis of hypertension is of paramount importance to the future of your patient. Remember white coat and masked hypertension. All patients, regardless of risk, will benefit from lifestyle modification. And there has to be a concerted effort, in my opinion, for the office to get together of how you're going to roll out the best rollout for getting patients to understand the importance and how to achieve lifestyle modification. A risk calculator should be used in primary prevention of those hypertensives less than 65 years of age without underlying ASCVD, diabetes, or CKD to predict their 10-year risk of ASCVD. Often younger people, no comorbidities, will be less than 10%, lifestyle modification only. In older and higher risk hypertensive populations, as was done in SPRINT, if a lower blood pressure goal is chosen, less than 130, check renal function and electrolytes more regularly as you reduce blood pressure. These patients are more prone to acute kidney injury with elevations in creatinine, to hypotension. So you have to be more vigilant in how often you're able to follow. Phone calls, nurse triaged phone calls can be very helpful as the patient who's older is lowering their pressure. How you measure blood pressure is a key determinant to what your target blood pressure should be, and informed patient clinician decision-making is imperative in implementing the 2017 ACC AHA Hypertension Guideline. Okay. You remember this from A Few Good Men, Jack Nicholson, you want the truth, you can't handle the truth. This is what the Guideline Committee considers the truth to be, and I'm sure this is causing some angst in some of you sitting there and listening to me. Well, I've tried to be the messenger. I've tried to explain this to you the best I could without you having to read 190 pages. There's more in the document. Let's go back to the questions, if you can pull those up. Which one of the following blood pressure classifications is no longer used to define blood pressure? Next slide. Please answer now. Normal, prehypertension, elevated pressure, stage 1 and stage 2, or you're unsure? Okay, we're real close to time. We'll only have 1 or 2 minutes for questions. I'm sorry. This clicker, we need to improve this. It's just not reaching you, and maybe you need to come up here. I'm not sure. But look at that. Oh, only 9 people answered. Well, prehypertension is the right answer. Okay. Oh, this is the first one. Yeah. Okay. Well, everyone got it. 9 people answered. According to the 2011-2014 NHANES hypertension data, what's happened to the prevalence from JNC7, 140 over 90 or greater, to the new 2017 guideline, 130 over 80 or greater? It increased from 32 to 46%, 50 to 60, 24 to 36, 18 to 40, or none of the above. Please answer now. Okay, we'll move on. The answer is 32 to 46%, but most of this increase is going to be in younger, less than 45-year age men and women, where lifestyle modification will only be used. Only 2% predicted by NHANES data, only 2% more drug use. That remains to be seen. And then finally, which of the following drugs are not recommended as initial therapy? And unless they have a compelling indication like heart failure with reduced ejection fraction or they're post-MI within the first 2 to no more than 3 years, beta blockers are not recommended, so the beta blocker is not recommended. Okay. Let me stop. It's a lot of material, and I apologize for trying to be comprehensive and maybe giving you maybe a little more than you needed to hear from 7 to 8 in the morning. But let me just answer a couple of questions, if I may, and then we'll get to our next talk on COPD. So we have the box here. Does anyone have a question or a comment? I'll take comments too. Yes. Please talk into the box, because we have web-based people.
Why was beta blockers taken out?
Beta blockers, when you look at them, first of all, the predominance of trials are atenolol-based, short half-life, truly a BID drug. Most clinicians use it once a day. And in the trials, they mostly evaluated beta blockers with a predominance of atenolol once a day. Stroke risk is greater compared to other agents, and there's really not all that much benefit compared to the other classes of drugs. So beta blockers do not have the evidence base, predominantly an atenolol-based beta blocker, for uncomplicated or non-compelling hypertension.
I have a question about the staging. Why is blood pressure more than 140 still kept at stage 2, not stage 3, because even though they have higher morbidity, mortality over time?
Because all blood pressure above 140 over 90, unless it's 180 over 110, where you really have to just ask some quick questions to make sure you're not dealing with anything more than non-adherence in a previously recognized hypertensive, because all those other stages, we know they're at high risk. So to make it simple, they put everything above that at stage 2.
So I have another question of the same token, that when you treat the blood pressure, your target is 130 or less. That puts you into a pre-hypertension stage. Why not a normal stage like anything else? Why because your target should be normal rather than pre?
Because, no, we're not using pre-hypertension anymore. So let's get rid of that, because these people are at risk. Because we just don't have evidence to drive down blood pressure to less than 120 over less than 80 in all individuals, unless you were to do it perhaps in the SPRINT trial using automated oscillometric blood pressure measurement. And because many systolic measurements are up to 10 millimeters or more higher by auscultation or by the way it's currently being done in our clinics compared to AOBP, 130 was felt to be an appropriate target to achieve.
In the trial where atenolol did not have evidence for decreasing stroke risk, was the blood pressure controlled with the atenolol, or was it that the atenolol did not control the blood pressure?
No, in many of these trials, blood pressure is controlled when it's measured in the atenolol trials. But what happens is, because atenolol is a short-acting beta blocker, you have what's called masked uncontrolled, or MUCH. This is a new term you're going to learn about in the future. This is why they're asking you to ask the patient when they last took, what their medications are and when they last took them. Because if you're in a short interval after they take a thiazide like HCTZ, or an atenolol beta blocker, you may be controlled when they're not controlled when they go to bed or before they wake up in the morning. Just in general, the outcomes are not very good with atenolol-based beta blockers. Certainly drugs like long-acting metoprolol and long-acting carvedilol are better, but they're still not as good as the diuretic, the CCB, and the ACE or the ARB. One more question.
These risk calculators don't seem to include family history, and it seems so important. Can you comment?
Yeah, it's very hard based on the databases that we have to put family history in there, but certainly people with premature atherosclerotic cardiovascular disease, that's an informed decision. That's something that you can bring to the table and talk to the patient about, how important you think that is. But it just couldn't be added to the risk calculator based on the variables and the data that they had to predict risk.